session. All right, everyone. So we are the Specialty Care Center within UNMC, and this is our second HIV ECHO session. It is titled HIV Prevention and Primary Care. We are so happy to have you all here with us today. And then today's subject matter experts are Dr. Jennifer Davis, Shawna Sunagawa, who's one of our pharmacists, and then Marci-Athey Graham, who is a DIS and PrEP navigator. All three of these experts have so much field experience, and I know that they're also happy to be here today, and they just have a wealth of knowledge to share with everyone. So this is going to be awesome. And then I'm the HIV ECHO facilitator. My name is Heather Sorella. I kind of help out with all of the back end things. And then our sessions are held the first Thursday of every month except January and July. So we won't see you next month, but we will see you in February. All right, everyone. And then this is just our session agenda for today. So we went over the welcoming, and this is just kind of our housekeeping. But so Dr. Davis will kick off the session with her didactic portion over HIV prevention and primary care. And then Shawna will follow Dr. Davis to present today's case study over PrEP and PEP. And then Marci is also attending as a guest subject matter expert, just to kind of help out with some air traffic control and just be another expert, just willing to help out with any questions. And then I will share some announcements at the end with a feedback survey as well. And now I will hand it on over to Dr. Jen Davis.
All right. Thank you, Heather. Everybody bear with me while I get my slides all set up. All right, are we seeing my slides correctly, everybody? Okay. So like Heather said, my name is Jen Davis. I'm one of the infectious disease and HIV physicians at the University of Nebraska Medical Center. Over at the Specialty Care Clinic, and I'm really excited to talk to everybody today about HIV prevention, specifically focusing on primary care. For everybody today, we have a lot to cover, so we're going to be going relatively quickly, but feel free to throw any questions you have or responses to questions I'm going to be asking into the chat, and we'll be monitoring that as well. And so let's get started. So I don't have any disclosures for today. A roadmap of what we're going to be talking about are, we're first going to be reviewing HIV testing. And then by the end of the session, I want you to have a basic understanding of the three main ways HIV transmission can be prevented. And so that's through testing and treatment as prevention, pre-exposure prophylaxis or PrEP, and then we'll very briefly touch on post-exposure prophylaxis and PEP. So first, I wanted to review HIV testing. So in 2019, the U.S. Department of Health and Human Services enacted an initiative called the Ending the HIV Epidemic. The goals of this initiative were many, but relevant to us, they wanted to reduce the new HIV infections in the United States by 75% by 2025 and by 90% by 2030. They want to advance health equity by scaling up key HIV prevention and treatment strategies. In 2021, an estimated 1.2 million people in the United States were living with HIV. For every 100 people with HIV in the US in 2021, though, only 87 of them knew their status. So that's 13% of patients have HIV and don't know it. And so as part of the Ending the HIV Epidemic, there's a goal to increase the estimated percentage of people with HIV who have received an HIV diagnosis, so then know they have it, to at least 95% by 2025 and remain at 95% by 2030. So how do we achieve this goal of people knowing that they have HIV? And that's through testing. And so the CDC actually recommends that everybody between the ages of 13 and 65 get a test at least once as part of routine care. So we call this your lifetime HIV test. Anybody who has ongoing risk factors for acquiring HIV, and quite frankly, anybody who's having sex, probably needs to be tested more than once in a lifetime. And you can determine that by talking with your patients and having joint decision making. So how are we doing on this, right? We've been able to test for HIV for many, many years. This CDC guideline came out quite a few years ago that everybody should be tested. Well, in 2021, a survey of US residents said that only 35% of them reported having had a lifetime HIV test. So that's 2 out of 3 of all of the people who are eligible for a lifetime HIV test, which is basically all the adults in the United States, had ever had one. So we have a seriously long way to go to reach this more people being tested appropriately. And so then we also have some data looking at breaking this down by state. This is a little bit more recent 2022 data. So how are we doing in Nebraska? Unfortunately, we're doing very, very poorly. This is us down there at the 4th from last. We can really do better. Only about 26% of the patients in Nebraska who were eligible for an HIV test had received one. So I really, really encourage everybody to think about testing. Always discuss testing with your patients whenever you see anybody. So why should we test? Dr. Fadul went into this a lot more last month when she talked to you, but essentially it's really important to test because of the clinical latency period of HIV. So if somebody is going to have symptoms when they acquire HIV, it's right at the beginning when they first get it in the first couple of months. Not everybody has it. Only 40% of people will have symptoms of acute HIV. And then they won't have any symptoms for months to years. It's this latency period. And so the only way to figure out that somebody has HIV is to test them. And so that's why it's really, really, really important. They could still be transmitting, their CD4 count and their immune systems are becoming compromised during that time. So it's definitely important that we start testing everybody. Okay. So let's start with my first question. A healthy 30-year-old female with 2 lifetime male sexual partners requests HIV testing during routine annual visit. What test do you order for her? And feel free to throw things in the chat. Let me see if I can get my chat to show up, which I'm for some reason. You seeing anything, my friends who are monitoring the chat for me?
Nothing from the chat yet.
Okay. That's all right. If nobody has any ideas, we can move forward and I'll tell you. So there's actually a lot of different tests that you can order for HIV. And the basics are there are nucleic acid tests. So this is looking for actual RNA of the HIV virus. There are antibody tests. So our standard antibody tests over here, and then also antigen tests. And so the reason that I want to bring up all the different types of tests is that different settings have different testing that they're going to do. And those tests only turn positive at certain times. So no HIV test can detect HIV immediately after infection. It's because of this window period. And so basically it's the time between HIV exposure and when a test can detect HIV in the body. So the very, very earliest that HIV can be detected is with a nucleic acid test or the HIV RNA test, and that can turn positive about 7 to 10 days. And then after that, the next thing that will turn positive is the antigens, the P24 antigen, that's around 14 days. And then the antibody doesn't turn positive until 21 days. So all of the tests that we can order are great. You just need to know exactly when that test is going to turn positive. And so you won't be falsely reassured when a test is negative if the patient has had a more recent exposure. So there is a testing algorithm for HIV, and I see that a lot of people order the panel in their hospitals, which is absolutely correct and what most people do. And so this is the testing algorithm for HIV in the United States and by the CDC. And so in most settings, in most clinical settings, that standard HIV antigen antibody 4th generation panel is what is ordered. And then this is the reflex testing algorithm that's been mentioned in the chat. But essentially, you don't stop here if the test is positive or if you're worried that somebody has acute HIV. So let's use our patient as an example. And so the patient that we were talking about before who requested HIV test, this sensitive HIV 1-2 immunoassay, the 4th generation antigen antibody test was ordered for her. And it actually returned positive. And so this is what it's going to look like in our EPIC system. So it says that the antigen antibody test is positive here, and then it tells you which part of that antigen antibody test was positive. And in this particular case, it was the HIV-1 antibody test. And so you can't just stop there. This doesn't mean that the patient has HIV. This is just a screening test. And so it needs to reflex, and more testing needs to be done to confirm the diagnosis. So if we look at the algorithm here with the CDC, which is always good to refer back to, the next thing that's going to happen is that this HIV 1-2 differentiation immunoassay is going to be done, and most labs will reflex for this. We don't have to order it. The lab will do it. If the HIV-1 antibody or the HIV-2 antibody are positive with this, that confirms the diagnosis of HIV, and then you'll refer them to care by an HIV provider. If the differentiation assay is negative, which is what happened for our patient, the next step is to order an RNA test. And so this is the HIV RNA test. This is really important because it can't be reflexed. It's a completely different tube that needs to be ordered and drawn. And so this is something where you have to bring the patient back to test it. And this is where a lot of patients get lost and they don't actually get their confirmatory RNA test. And so with our patient, she had a positive screening test, a negative differentiation assay, and then we sent her RNA, and the RNA test returned not detected or negative. So the interpretation for this test is actually a false positive. And so Marci's asking, yes, Marci, I will address this at the end if that's okay with you. Just so we can keep moving. So with the HIV testing take-home points for everybody, testing is prevention in order to prevent people from transmitting HIV to others, and also for them to become sick and have complications of HIV. You need to test to know that they have it. If a screening test is positive, you can't just stop there. Any positive test should be confirmed with a confirmatory differentiation assay. I will say that there's caveats to this, but most labs will reflex to this, and then an HIV RNA PCR or a viral load to confirm the diagnosis. Always send an HIV RNA if you're worried about acute infection, because that's the test that detects the HIV infection the earliest, but again, only 7 to 10 days. So something to think about. All right, so my next question, and feel free to put your answers in the chat. This is a true or false question. If someone has HIV, they will always be able to give HIV to sexual partners. What do people think? True or false? False. I love the falses that are coming into the chat. You guys know too much already. Okay, this is perfect. So you're exactly right. This is false. I won't go into the studies behind this, but basically we know that U equals U for sexual contact. We have a lot of studies that show as long as somebody with HIV is undetectable, and functionally speaking, this means they have a viral load that's less than 200, they cannot transmit HIV to another person via sexual contact. So very, very, very important that people get diagnosed with HIV, they get on treatment, then they can't give HIV to anybody else. So fantastic. And this is U equals U. There's tons of U equals U bling out there, but we always love to talk about it. Okay. All right. Next question. A healthy 23-year-old cisgendered female comes to her routine wellness exam with you. She tells you she was diagnosed with gonorrhea at a local clinic 3 months ago and was treated with 1 dose of IM ceftriaxone. Should you talk to her about PrEP? What do people think?
Yes.
Yay! I'm getting a lot of yeses in the chat, which is fantastic. You're absolutely right. So before we talk about PrEP, we need to understand HIV risk, because that really will inform who we talk to about PrEP and when. And so this is a pretty nifty map. I like it. It's looking at the lifetime risk of HIV by state. It was presented at a big international HIV conference back in 2022. So this is the lifetime risk of HIV diagnosis in the United States for all comers. And that is actually 1 in 20. So 1 in 20 people in the United States, doesn't matter who you are, will acquire HIV in your lifetime, which the first time I heard that statistic was a lot higher than I thought. If you look at the map, this is breaking it down into state and the particular rates in different states. And the darker colors are the higher lifetime risk, with the highest actually being the District of Columbia at 1 in 39. Here in Nebraska, we're a little bit better than the national average at 1 in 310. Seems like it should be reassuring. This is breaking down the prevalence of those living with HIV in Nebraska in 2021. Again, the darker colors are where there's a higher prevalence of those living with HIV. And you can see that Douglas County here, and then Hall and Custer counties out in central Nebraska actually have the highest rates. So even though overall in Nebraska our rates aren't that high, there's certainly hotspots where we need to think about HIV a little bit more than in other locations. So then looking back to national data, if we break down the lifetime risk of an HIV diagnosis among all men in the United States, it's 1 in 76 lifetime risk amongst all men. And unfortunately, we have a lot of racial disparities, and the risk for Black men actually is 1 in 27, and then Hispanic men is 1 in 50. So really, really, really high with a lot of racial disparities. If we then look at women, the overall lifetime risk of HIV acquisition for women in the United States is 1 in 309, so a little bit lower. But then unfortunately, the racial disparities still persist, and Black women have a 1 in 75 risk of acquiring HIV, so definitely something to think about. And then if we look at risk categories, so this is looking at the lifetime risk of HIV diagnosis amongst MSM in the United States. And so overall, MSM have a 1 in 7 lifetime risk of acquiring HIV in the US. And then unfortunately, the racial disparities persist here, and Black men have a 1 in 3 lifetime risk of acquiring HIV, this is updated data from an international HIV conference called CROI in 2024. The previous number was 1 in 2 for Black MSM, but we really need to do a lot better than 1 in 3, quite frankly. This is hot off the presses data. So this is actually a perspective piece that came out in the New England Journal of Medicine in October of 2024. Looking at overall, we're doing some pretty good work in trying to decrease the new HIV infections in the United States overall. This is this blue line right here. But unfortunately, we're losing a lot of ground with our young Latino MSM, as you can see, and the rates are really skyrocketing. Okay. All right, so what about PrEP? We have PrEP. Is PrEP getting to who it needs to get to? And so overall in the United States, the number of PrEP prescriptions who are being prescribed to people who are at risk of HIV acquisition or have an indication for PrEP has been increasing since 2019. It's up to 36%. That's still 2 out of 3 patients who need PrEP aren't getting a prescription for PrEP, and this is all comers in the United States. Again, our racial disparities persist here. And so we already talked about how Black MSM or Black men have the highest risk of HIV acquisition, specifically Black MSM. And unfortunately, they're getting the fewest number of PrEP prescriptions, with also Hispanic and Latino men, Hispanic and Latino. This isn't just men, this is all racial races, or all genders, I apologize. So fewer prescriptions among Black people, fewer prescriptions among Hispanic and Latinos, and then we're doing really well amongst white people for PrEP prescriptions. And then again, more men in the United States are getting PrEP prescriptions than women. So just something to think about. And this is everybody who has an indication for PrEP. So these are women who need it, and only about 15% of those patients are getting it. So let's talk about PrEP. And what is it? I highlight this here because obviously PrEP is pre-exposure prophylaxis. It's medications we can give to help prevent HIV. I want to just remind everybody about low-hanging fruit of barrier protection. So dental dams and condoms. PrEP prevents against HIV, but doesn't prevent against other STIs. So just something to think about to help your patients protect themselves. So this is a very busy slide, but I just wanted to get you familiar with it. This is a very useful table from the 2021 PrEP guidelines in the United States, and it's a pretty good one-stop shop for you to refer to about how to prescribe PrEP to your patients, who should be talked to about PrEP, who's eligible, what the clinical eligibility is, what you can prescribe in the follow-up care. So really good one-stop shop. But just as a review for us, so some risk factors to think about for people to meet an indication for getting PrEP are obviously MSM, like we talked about. Anybody who's having sex, really. So heterosexual couples as well. Anybody who's using injecting drugs, anybody who has a sexual partner with HIV, anyone with an STI in the last 6 months. This was an update in the recent 2021 PrEP updated guidelines. Anybody with multiple sex partners, inconsistent condom use, needle sharing, living in a high prevalence area or network. So for example, somebody who's coming from DC where there's a higher lifetime risk. And so 2 of the ones on here I want to highlight are anybody with an STI in the last 6 months. It's a lot of patients. And then anybody with inconsistent condom use. And I'm not sure I know anybody who uses condoms 100% of the time, including with oral sex. So most of our patients are going to be criteria for at least being talked to about PrEP. I won't go into detail on this, but this is a slide from Doug Krakauer, who is a PrEP expert who works at Beth Israel Deaconess in Boston. And essentially, this is a flow chart, is anybody who's having sex at the top, and the answer down at the bottom is either prescribe PrEP or discuss PrEP. Doesn't matter how you get there. So I love this. And per the CDC, we should prescribe PrEP to anybody who asks for it, including sexually active adults and adolescents who do not report HIV risk factors. And this is a change in the 2021 guidelines. We used to say if they, don't have risk, then we don't need to prescribe it. Now give it to anybody who asks for it and talk to anybody else about it. So I want to briefly go over all the different PrEP regimens. So we have daily oral PrEP, on-demand oral PrEP, and then long-acting PrEP injections. So the main thing that we think about as PrEP is Truvada, or tenofovir disoproxil fumarate and emtricitabine. It's the standard PrEP. It's an ARV or antiretroviral combination pill. The brand name is Truvada. There are both reverse transcriptase inhibitors. It's one pill that's taken once a day. And this was actually approved for PrEP in July of 2012, so a long time ago. And this has been approved for everyone. You can get Truvada daily if you are MSM, transgendered women, cisgendered women, those who are injecting drugs. Anybody can get Truvada. So some eligibility criteria for using PrEP. You need to have a negative HIV test in the last 7 days prior to getting a PrEP prescription. You need to have no signs and symptoms of acute HIV, because remember that antigen antibody test is not going to detect acute HIV. And so you go down a different treatment testing algorithm for acute HIV. You need to have healthy kidneys. For using Truvada, you have to have a creatinine clearance of greater than 60. So something to think about. And then you can't be on any contraindicated medications, of which there are incredibly few, but just something to think about. It's not a contraindication to using PrEP, but you should check everybody who you're considering using PrEP in for hepatitis B, because both tenofovir and emtricitabine treat hepatitis B. And if that treatment is withdrawn, you can have rebound hepatitis B. So you always need to know their hepatitis B status before you prescribe tenofovir-based PrEP for them. Some adverse effects of Truvada to think about are some GI upset that can be mild in the first couple of weeks after starting it, but usually goes away if they can tolerate it. Patients can have some subclinical bone mineral density loss that doesn't lead to fragility fractures, but it can definitely compound people who already have osteopenia. It can, in very rare instances, cause kidney toxicity, but usually doesn't happen in our young and otherwise healthy individuals. This is people who are older and already have CKD or at higher risk. And then in very rare instances, you can see resistance formation if somebody gets HIV while they're on PrEP. Usually if they're taking PrEP correctly, they don't get HIV while they're on PrEP, but a lot of the time what happens is somebody will be on PrEP, they'll run out, they'll stop taking it for whatever reason, and then restart it, having acquired HIV in the meantime and not knowing about it. And that's when you're really at risk for HIV acquisition. Another PrEP that we can use is Descovy or tenofovir alafenamide and emtricitabine. This is the newer version of Truvada. It was studied in the Discover study and was found to be non-inferior to Truvada for PrEP use in MSM and transgendered women only. This is not for cis women. This is also a pill taken daily. It has a very similar safety profile to TDF-FTC, but there's less kidney toxicity, less bone mineral density loss. You can use this up to creatinine clearances of 30 or higher. It's much more expensive than Descovy than Truvada because there's no generic currently. We do see some increased weight and cholesterol in those on TAF, and so it's something to think about. It is a smaller pill, so that's a consideration for some patients. In general, in most situations, we still favor Truvada over Descovy. A lot of people want to talk about on-demand PrEP, which is the 2-1-1 strategy. So I'll touch on it briefly. It's an intermittent rather than daily dosing strategy for Truvada and MSM and transgendered women only. It's basically you take 2 pills 2 to 24 hours before sex, 1 pill 24 hours later, and then another pill 24 hours after that. It was shown to be efficacious in a couple of studies and non-inferior to daily oral PrEP in those studies. It is not FDA approved, but we do prescribe it for patients occasionally. You cannot use this in cisgendered women, and it's only with Truvada. You can't use Descovy for this, okay? As a caveat, do not use on-demand PrEP with chronic active hepatitis B, because again, you'll be intermittently treating that hepatitis B, and you don't want to do that. We now have one form of injectable PrEP, and this is long-acting injectable cabotegravir, which is an integrase inhibitor. It's approved for MSM, transgender women and cisgendered women. It was studied in 2 landmark trials, was actually shown to be superior in women in particular, mostly due to adherence and not taking the Truvada as consistently, but it's very, very, very effective. However, if somebody fails, and what I mean by that, if somebody gets HIV while they're on cabotegravir, they can develop integrase resistance and this Levi syndrome, long-acting early viral inhibition syndrome, which is problematic because it takes a while to detect the HIV, and they can have very, very low-level viremia. Very, very breaking news. We are hopefully going to have another injectable PrEP option in the next couple of years, with a trial that just came out showing really, really effective lenacapavir, which is a sub-Q injection every 6 months, but again, not FDA approved yet. It's going to be a few years before this is prime time. So just a recap, for our different versions of PrEP, so Truvada daily, Descovy daily, Truvada on demand, and then long-acting cabotegravir. They, MSM and transgender women can receive any of these forms of PrEP. For cisgendered women, we're really limited to Truvada daily and then long-acting injectable cabotegravir daily. I won't go into detail on this, but there are very few drug interactions that you need to worry about for the different forms of PrEP. I'd recommend using your drug interactions database if you're going to be prescribing it. This is an example one for the University of Liverpool has a fantastic HIV drug interaction checker. Just run it through, make sure that you're not going to either decrease the efficacy of other meds or your PrEP by prescribing it. How do we monitor? So in general, we want to bring in patients every 3 to 6 months for STI testing. We recommend doing triple site or whatever sites are involved during sex for patients. So oral if they perform, or pharyngeal screening if they perform oral sex, their rectal screening if they have receptive anal intercourse, and then urine or vaginal for our individuals who have a vagina. Want to do syphilis testing because also the syphilis rates in Douglas County in particular and a lot of Nebraska are really high. And then for our MSM, think about doing yearly hepatitis C testing as well. At your 3 to 6 month visits, you want to get an HIV antigen antibody screening test as well as an HIV viral load. You want to assess their renal function every 6 months, especially if they're on Truvada. It can be spaced yearly if they're young and otherwise healthy with no baseline kidney dysfunction. And then always you want to discuss access to clean needle syringes and drug treatment services for those who use drugs. Okay. When to refer to a specialist if they have HIV infection, or sorry, Hep B infection, if they have renal dysfunction. If they're interested in injectable cabotegravir, we have it here at the Specialty Care Center, and there are a few other clinics around Nebraska who are doing it. If there are any other complicating factors, if you're ever unsure, it's always okay to e-consult if that's available to you. Refer to an ID clinic or PrEP clinic at the Specialty Care Center. There's also this National Clinician Consultation Center, which is available during business hours. It's free. They provide expert consultation on PrEP during business hours. It's phenomenal. You can do an online case submission or just call them. Really, really good resource for people. Briefly, cost should not be a barrier. For patients without insurance, you can get it with a GoodRx prescription. You should be covered by Medicaid and insurance under the ACA. There are medication assistance programs from the drug companies, copay cards. There's the Ready Set PrEP program. Cost should not be a barrier to getting patients PrEP. Okay. One last, because we're running out of time, one last very brief case. We have a 25-year-old cisgendered male patient who comes to an urgent appointment with you. He reports that he had receptive anal intercourse with a new partner last night and the condom broke. He doesn't know the HIV status of his partner and he has no way of contacting. What do you tell him? So this would be a situation in which we would use post-exposure prophylaxis. Exactly. Discuss PEP. I love this. Okay. Post-exposure prophylaxis instead of pre-exposure prophylaxis. So this patient has been potentially exposed to HIV. They need non-occupational post-exposure prophylaxis. Very briefly, PEP is non-occupational post-exposure prophylaxis. It's 3 antiretroviral agents given within 72 hours after potential HIV exposure and continue for 28 days. Okay, so instead of the 2 agents that we use for PrEP, it's 3 agents. You can stop PEP if the HIV status of the source patient is known to be negative or 28 days are reached. You need to do baseline testing for HIV, as well as repeat testing at 4 to 6 weeks and 12 weeks after the exposure. And that repeat testing is really, really important. A typical regimen is Truvada plus an integrase inhibitor, usually dolutegravir. I will say they're going to be updating the PEP guidelines relatively soon, and it might simplify this, but this is our current regimen that we recommend. Don't forget to test for other STIs and treat empirically if needed, as well as hepatitis C, and assess hepatitis B immunity status and vaccinate them if they're not immune. So there's some really good algorithms on how to prescribe PrEP and what times how to prescribe PEP and at what times you need to think about it. This is from the CDC, but there's always resources that you can refer to. So some take-home points for today. HIV is still out there and our patients are at risk. Please test everyone for HIV and more than once if they're having sex. U equals U, testing and treatment are prevention. And then PrEP and PEP are effective ways to prevent HIV transmission. So I will open it up for questions, though I know we want to jump into the case and there will be some additional resources for everybody. I will stop sharing. So that Shawna can take over our case.
I will pull